Hey podcast listeners, Jim Siegler here. It's been 5 years since the release of our first episode of the Brainwaves podcast, a podcast 5 years in the making. With over 220 episodes covering a broad spectrum of neurology and medicine, we've always tried to bring in guest speakers and thought leaders who represent all parts of the US and half a dozen countries, nearly 40% of whom were women and 1/3 were non-white, representing all disciplines of neurology. And when you think about it, this may seem like our program lacks diversity in its contributors, but actually these numbers are better than what we see among academic neurologists. That's for another time. Suffice to say, it has been a tremendous pleasure of mine these past years to produce the program, to talk with these outstanding clinical leaders, and play just a small role in your medical education. And now, it's with a heavy heart that I have to tell you that the Brainwaves podcast will be retiring. We've had a good run. 1.5 million downloads. But it's time for each of us to look forward to the next step in our education and our own personal growth. This is an opportunity for all of us to carve a new path in our lives and our careers, to take what we've learned and build from it. Brainwaves will remain on iTunes and Stitcher and your Amazon device for a couple months, so you still have time to access all our prior shows, including this episode, which we've re-recorded and updated since its original release back in 2016. I hope you enjoy it. Various forms of progressive paralysis, ascending or otherwise, have been recognized for centuries. While Jean-Baptiste Octave Landry has been credited with an apt description of several patients with distal sensory disturbances and ascending weakness after a viral prodrome, the first comprehensive description of an ascending paralysis would be described later by William Osler in 1892. But Osler's early descriptions were limited by the lack of available diagnostic techniques, specifically the lumbar puncture. Originally called Quincke's puncture, after the German physician credited with the technique, the lumbar puncture had been successfully implemented before Osler's 1892 description of the ascending paralysis. However, this procedure would not achieve routine diagnostic use until the 20th century, long after Osler's clinical monograph. Eventually, in 1916, 3 physicians by the names of Guillain, Barré, and Stroll wrote up a case series of 2 French soldiers with a summary statement that perfectly characterized the disease process.
We bring to attention the present note, a clinical syndrome that we have observed in 2 individuals, a syndrome characterized by motor difficulty, abolition of deep tendon reflexes with preservation of cutaneous reflexes, paresthesias without demonstrable objective sensory loss, pain on deep palpation of large muscles, minor modifications in electrical reactions of nerve and muscle, and increased albumin in the cerebrospinal fluid, with most notably absence of cellular reaction, albuminocytologic dissociation.
Based on this description, in conjunction with that of Landry's earliest report, the eponym Landry-Guillain-Barré-Stroll syndrome was generated, or more simply, the Guillain-Barré syndrome. Welcome back to Brainwaves. I'm Jim Siegler, and today we'll be reviewing the Guillain-Barré syndrome. While the history of GBS is actually pretty amusing, we've got a lot to cover this episode. And for those who are interested in the historical background, in particular Guillin's contention that his disease was entirely separate from Landry's earlier report, and the fact that Guillin made no mention of Landry's 19th century description of a similar process, I recommend you take a look at the 1990 review by Arthur Asbury in the Annals of Neurology, or the 1994 perspective by Adele Afifi. I've seen many students and physicians use the terms GBS and acute inflammatory demyelinating polyradiculoneuropathy, or AIDP, interchangeably. But this is a mistake. GBS includes a wide variety of acquired polyneuropathies, only one of which is AIDP. And true, AIDP is the most common variant of GBS in the United States, accounting for 80% of all patients with GBS. Each of the other variants beyond this one are less common. For example, acute motor axonal neuropathy is clinically indistinguishable from AIDP in the absence of electrophysiologic or serologic testing. But unlike AIDP, which typically follows a viral illness like CMV or EBV, AMON often complicates infections with Campylobacter jejuni. Also, unlike AIDP, AMON has a strong association with ganglioside antibodies GM1 and GD1A. It rarely has sensory formications or autonomic involvement, and AMON is the more common variant of GBS in China. Another variant, the pharyngeal cervical brachial variant, progresses from the neck downward as opposed to the characteristic ascending course of progression in AIDP, and this can mimic botulism in infants. The Miller-Fisher variant, which presents with a combination of ophthalmoparesis, areflexia, and/or ataxic gait without any weakness, accounts for 5% of all GBS patients. The Fisher variant is clinically relevant in that there is a ganglioside antibody that's strongly associated with it, the GQ1B antibody, which can be identified in the peripheral blood. There are also rare variants in which motor manifestations are entirely or nearly entirely absent. Consider the Bickerstaff brainstem encephalitis, which can be mistaken for delirium or critical illness. Bickerstaff's is basically the Fisher variant plus encephalopathy. And, like the Fisher variant, there's an association with the GQ1B antibodies, seen in 66% of cases of Bickerstaff's. Even more rarely, a pure large fiber sensory variant can present with progressive sensory ataxia and autonomic disturbances, mimicking an anti-HU paraneoplastic syndrome or Sjogren's neuronopathy. Rarely, I've had inpatient consultation requests for severe pandysautonomia, and while diabetes, uremia, drugs, toxins, and amyloidosis are more likely, a GBS variant may also be included in this differential. When I was a resident, having recently rotated at the Children's Hospital, I remember being asked about the neurologic complications of vaccinations. Yes, including autism. And no, there's no relationship between vaccines and autism. But is there a relationship between vaccines and GBS? Well, that's a tough question. The relationship of GBS with vaccinations is so complex and controversial that entire manuscripts and books have been dedicated to it. But for now, we'll start by briefly summarizing the available evidence here and acknowledge both sides of the argument. In order to simplify things, I'll focus on the data pertaining to influenza vaccines. As everybody knows, it is accepted that GBS follows an antecedent infectious illness by 4 to 6 weeks, whether it's Campylobacter, or as we saw a few years back, the Zika virus. However, influenza infection is not traditionally thought to be a big trigger for GBS, according to many experts. In considering the largest influenza outbreak in recorded history, the Spanish influenza epidemic of 1918 to 1920, which affected up to a quarter of the world's population, there were no subsequent reports of post-infectious ascending weakness, areflexia, or other descriptions of what would later be called the Guillain-Barré syndrome. Sure, GBS had only been identified 2 years before this outbreak, but still, we didn't see a flurry of papers describing any outbreaks of ascending paralysis during this time period. Furthermore, many of the subsequent studies over the next several decades, through the 1970s or so, proving a relationship between GBS and vaccinations failed to demonstrate any causality. The significant correlations are built on associations rather than causation, but the arguments are certainly compelling. So let's talk about them. Take, for instance, one French study of 405 patients with GBS, which showed a strong correlation with influenza-like illnesses and GBS cases, nearly 20% of which had serologic evidence of recent influenza infection. Similar findings were observed in a 15-year cohort study out of the UK, where investigators showed a robust association between GBS and a recent influenza-like illness, but no relationship between GBS and the flu vaccine. According to another case control study from a UK registry, influenza-like illnesses increased the odds of GBS by as much as 18-fold. From 1993 to 2002, England also witnessed a spike in hospital admissions for GBS contemporaneously with spikes in positive flu serologies. But as I said earlier, these data, while robust and longitudinal, fail to show a causal relationship. So if we make the intellectual leap, accepting that flu might cause GBS, could a flu vaccine, by preventing influenza, also reduce the risk of GBS? Well, it turns out there's a slight risk of GBS among patients who receive the flu vaccine compared to patients who do not get vaccinated. But it's a very tiny risk, like 1 in a million chance tiny. And now this begs the question, does getting the flu vaccine prevent influenza-associated GBS? Meaning, are you more likely in a given year to develop GBS from the flu or from a flu vaccine? Well, this is another really tough question, and after a lot of research, I don't think we have enough data to make any solid conclusions. And certainly, the incidence is so low that no prospective study has been performed because it would lack the statistical power to answer that question. You might need tens or hundreds of millions of patients to find a significant difference in outcomes. There's no question that the flu vaccine is safer than getting the flu is, even if there is a very tiny risk of GBS that comes with it. Even so, the incidence of post-vaccination GBS is decreasing from 17 per 10 million vaccinations in 1993 to 4 per 10 million vaccinations in 2003. And more recently, probably more relevant for the COVID pandemic, people are afraid to get a vaccine, especially the COVID vaccine. And while there were some case reports of SARS-CoV-2 and GBS, now this possible relationship has been pretty much ruled out by 2 studies published in the same brain paper by Caudie and colleagues. No increase in cases of GBS with rising rates of SARS-CoV-2. But whether the vaccine and the immunogenicity of the mRNA or adenoviral vectors serve as mediators of an autoimmune response, that's another question. And right now, we just don't know. Before you're misled, though, by any case reports or cohort studies that suggest a relationship between COVID vaccines and GBS, consider this important statistical argument that was made by Michael Lunn and colleagues. Assuming 4 billion people in the world receive a COVID vaccine, right now we're just at over 1 billion, if 4 billion get the vaccine, 13,000 people are going to be expected to develop GBS during the weeks that follow 1 or 2 immunizations. That's 3 people with GBS for every million vaccine recipients, which is what we know is going to happen. That's just what we expect. In the US, where almost half of our citizens have received at least 1 dose, we could estimate that 450 people have developed GBS after the vaccine. Therefore, not only is it possible, but it's probable that papers are going to crop up incriminating the vaccine as a causal mechanism for vaccines and GBS. But it's up to you to look at these data critically and say, is the risk of GBS with the vaccine greater than the expected risk in the population? Let's move on to treatment and prognosis. I should be clear here that, as usual, Brainwaves is intended to provide medical education and not to guide treatment decisions. Specifically for AIDP, treatment consists of plasma exchange, divided over 5 alternating days, or intravenous immune globulin at 2 grams per kilogram divided over several days, usually 5. Both are considered equally efficacious. Neurologists have also divided the dose of IVIG over 2 days in patients who have myasthenia gravis or CIDP, patients who aren't naive to pooled immunoglobulins, and we've been giving IVIG over 2 days to patients who have the thrombotic syndrome that's associated with antiplatelet factor 4 antibodies among COVID vaccine recipients. In GBS, plasma exchange was the first method studied, and compared to placebo, it reduced the duration of ventilator dependence by 2 weeks, and it reduced the time to walk unsupported from 41 days to 32 days. The combination of these 2 therapies, plasma exchange and IVIG, has been systematically evaluated, and we found that no therapy was superior to the other. And obviously, plasma exchange following IVIG is likely to clear out the immune globulins you just infused. One board question you'll probably encounter is whether IVIG or plasmapheresis improves long-term outcomes or mortality in GBS, and the answers are no and no. Typically, the decision for plasmapheresis or IVIG depends on the type of the patient and the risk-benefit ratio of each situation. In general, IVIG is quicker and easier to administer, but in patients with IgA deficiency, it's an absolute contraindication. You may also choose to defer IVIG in patients with a known predisposition to clotting, since it increases the risk of venous thromboembolism. Other risks of IVIG include an aseptic meningitis, which is often self-limiting, a mild infusion reaction, rash, and a less than 2% risk of acute kidney injury. On the other hand, the provider might want to avoid plasma exchange in patients on active anticoagulation, since bleeding risk is considerable with plasma exchange as we're removing those clotting factors. Since it does take longer to complete a course of plasma exchange, about 10 business days, it may also increase the risk of certain hospitalization complications, like a central line infection or deconditioning, and delayed rehabilitation placement. Now the next question is, for patients who respond poorly to IVIG or plasma exchange, is a second round of treatment effective? And is a second round safe? I just mentioned that sequential IVIG plus plasma exchange does not improve outcomes in GBS, but what about 2 doses of IVIG? The results of the Dutch GBS study group were just published in Lancet Neurology back in March of 2021, and they shed some light on this question. In this double-blind, randomized, placebo-controlled trial of patients with severe GBS, patients who were treated with IVIG were followed by a second round of IVIG or placebo 7 to 9 days later. 93 patients were included in the primary analysis. There was no signal of improvement with the extra dose of IVIG. What's more, patients who received a second dose had twice as many adverse events as the placebo arm, 35% of patients versus 16%, leading to the death of 4 patients in the treatment group. So not only is extra IVIG an expensive treatment, not only is it ineffective when dosed shortly after the first round in patients with severe GBS, but it's also harmful. And we're left to conclude that one dose is enough, and even for poor responders, it's not worth the risk to treat more. Besides immunomodulatory therapies like IVIG and plasma exchange, treatment for GBS is largely supportive. All patients are typically monitored for pulmonary function, usually with a negative inspiratory force or vital capacity at routine intervals, and intubation is considered in patients who have a declining respiratory function. Often, because GBS symptoms may continue to deteriorate up to 4 weeks after onset, patients may require monitoring during this period as they worsen or until symptoms plateau. The prevention of deep vein thrombosis in non-ambulatory patients using prophylactic anticoagulation or compression stockings should also be pursued. Early physical therapy and rehabilitation is generally encouraged, when possible, to prevent associated deconditioning and to restore muscle function. The big question that we're always left with is, who's going to get better, and when? Like many diseases affecting the nervous system, improvement can be quite delayed. And, like I mentioned before, treatment with plasma exchange or IVIG can reduce the non-ambulatory time from a month and a half to just a month. And a month is a long time to be stuck in bed, or in a wheelchair, or using a cane. But not everybody recovers fully. As many as 1 in 20 patients may die from GBS complications, which can include sepsis or ventilator-associated pneumonia, ARDS, or autonomic dysfunction. Among survivors, 20% remain non-ambulatory 6 months later, and full recovery, which is more the rule than the exception, is reported to take an average of 200 days. Patients less likely to achieve these positive outcomes include those who become ventilator dependent, a complication that's associated with a mortality rate of 1 in 5. Other poor prognostic features include rapid symptom progression, older age, greater than 60 years as a common cutoff, and features suggestive of axon loss as opposed to demyelination. For instance, reduced CMAPs on nerve conduction study, or absent motor responses, or preceding diarrheal illness that suggests Campylobacter infection, which is associated with axonal degeneration as opposed to demyelination. A GBS outcome score has been developed called the Erasmus GBS Outcome Score, or EGOS, which incorporates age, preceding diarrheal illness, and a GBS disability score. And there's also a modified version of EGOS, which is utilized at some centers for prognostication. Returning to that Dutch randomized clinical trial of a second IVIG dose, those trialists enrolled patients who had a poor EGOS score. So it is a useful scoring system in research as well as clinical practice. So now you know a little bit more about Guillain-Barré, its history, the variants, the controversial connection it has to vaccinations, and likely some upcoming hype about COVID vaccine risks, the treatment of GBS, and the prognosis. Again, I want to thank you for taking the time out of your day to listen to the program and for being a member of this online community. Brainwaves is wrapping up soon, and I will certainly miss talking with you. As a reminder, Brainwaves is intended for medical education only and should not be used for routine clinical decision-making. Today's program was produced at a Studio 3 in Philadelphia, Pennsylvania by myself, Jim Siegler. Our music was courtesy of Lee Rosevear, sound effects by Mike Koenig and Daniel Simeon. Take a look at the references in the show notes when you have a second, and there you'll find our source material for today's episode and for each show that we've put out. Hope you find it useful. I'm Jim Siegler. Be well.